You're here for the Cognitive, Behavioral, and Acceptance-Based Approaches for Managing Pain, Tools for Pain-Related Suffering webinar that we're hosting today. We're very excited to have you here today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar is co-sponsored by ourselves, CIRPD, and Pain BC, and we're doing it in collaboration with the Canadian Pain Coalition. It's also made possible through the support of the Direct Access Program through the BC government. As I mentioned, my name is Tanya, and I'll be moderating today. Online we also have Lisa Mighton, who will be handling the question and answer session, and our presenter today is Dr. Matthew Graham. Matt Graham is a registered psychologist and senior manager of clinical practice at Orion Health. He's been with Orion Health Rehabilitation and Assessment Centers since March of 2008. After graduation from UBC's Counseling Psychology PhD program, Matt continued his involvement in research by initiating and helping to conceptualize a joint research project with the University of Calgary. This critical incident study with chronic pain clients was conceptualized with the goal of having it include client voices in program development. Matt has also developed and implemented a multicultural competency development program for the Orion Health Surrey Clinic. We're very glad to have you today, Matt, and I will hand it over to you.
Well, thanks very much. Yeah, it is a privilege to be able to come and talk to you all today. It's a tall order. I have to check my own expectations because by the end of this, I want you all to have had a beautiful experience of, seeing what cognitive behavioral and acceptance and commitment type approaches can do for you. But I know that it takes a lot of work, so I do want to make this an experiential program or experiential talk, and also make sure that you get the appropriate background to what we're talking about. So I want to start by laying a few of my cards on the table. When it comes to dealing with persistent pain, I always come back to the idea of how important it is to embrace it in its full complexity. So definitely adhere to the biopsychosocial spiritual model. I think psychological intervention definitely has its place, and it can inform physical treatment as well. First things first, though, if medical closure is essential, right? You need to have a clear sense of what your diagnosis is. Are you at sort of a medically stable place? The other thing that I think is really important, and important to say, you're hearing from a psychologist, but I do not believe at all that pain is all in your head. And I think actually that some of the messaging and the work that's been done by CRPD and other agencies is really getting that message out, that pain is more complex. You need to understand how the brain, spinal cord, nervous system, your neurochemistry all works to sometimes maintain pain responses when it doesn't quite fit the nature of the injury. Other assumptions, the techniques I'm going to talk to you about, I used to think for many years that you can't control pain directly, and that we learn these techniques to so that you can manage more effectively the suffering that relates to pain. And I still think that that's true, but I also think that some of the techniques can actually help you over time impact your experience of pain. I also know that these techniques, these ideas will only work if a person develops a pattern of disciplined practice. And I do buy into, and we'll get into a little later talking about the role of paradox in treatment of chronic pain. And essentially, some of the things that clinicians ask you to do, some of what the research seems to be saying seems foolish at first blush. But actually, it's when you consider your own patterns of relating to pain and look at new ways of doing it, they can actually be quite profound. And so that, to me, that's how I understand paradox. It's probably the wrong definition, but that's where I would come from. So my goal today, for sure, is to introduce you to cognitive behavioral therapy and acceptance and commitment therapy, especially as they relate to the treatment of pain. I want to give you just a little research background as to why are these approaches, who's researching them and telling us that they're important. I want you to leave today's talk with a framework and some skills that, yeah, okay, this makes sense for me to begin to pursue some of the things being offered. So the intended outcomes for today, the theme running through this whole talk is an examination of the mind-body connection when it comes to a persistent pain problem. I want to give you experience of using breathing to regulate distress. Some of these, the next bullet are, I'm not going to go into them because I will as we get further in the talk, but essentially they're ideas or techniques coming out of either cognitive behavioral approaches, and then further on in this list, acceptance and commitment therapy type approaches. I think that's all I'll say about that. I guess I do want to say that as I invite you into practice, I'm not there with you, right? So, and you may find actually that as we do these brief practices, you're getting something good out of it, and then you're jerked back out of it, to continue on in the talk. So just be aware that ideally I would love to talk to you for 3 hours or 6 hours and weave in and out of practice and theory, but we don't have that luxury. So if you know, just check yourself. If you know that it might be difficult for you to move in and out of specific practice, whether it's breathing or looking at your own personal patterns and then coming back to a talk, maybe just flag that and just watch, don't go there with us, and then something that you can go back to and take a look at later. So let's start. Diaphragmatic breathing is a technique that fits within the cognitive behavioral paradigm. And breathing is at the core of life. Obviously, that's, maybe I didn't need to say that. However, living with persistent pain, often a secondary outcome is that people don't breathe properly. And because of pain-related distress, because your mind's maybe not on it, I find in my clinical practice that most people are breathing quite shallow into their upper chest. So let's try it. You can see the rationale behind. Pain creates a stress response, and our cognitive functioning doesn't work very well under stress. And so this is a good place to start. It's a simple skill. Let's try it together. So if you're willing and if you feel like it's might be safe, this one's pretty safe, one hand on your chest and another hand on your stomach. I want you to slowly breathe in through your nose, deep into your stomach. Imagine that there's a balloon in your stomach and that it's expanding. And I want you to breathe out very slowly through your mouth. I want you to get into a rhythm of just breath after breath, paying attention to the breath as it comes in. Let your mind rest on it as it goes all the way down deep into the stomach. Stomach expands. And as you breathe out nice and slow through your mouth, and we'll do 2 more of these. Again, we're engaging in a behavior with a specific rationale that has an impact on perhaps the distress that pain creates. One more long breath and breathe out. And so this is often an introductory skill that we bring to the folks that come through our interdisciplinary pain program. Again, it's not something that immediately takes pain away, but over time what we can do is change the level of reactivity to our pain experience by developing a different set point for relaxation, decreasing reactivity and being aware of just how our breathing is going. So again, wanted to pepper experience and lecture. So 2 recent articles just reiterating the fact that cognitive behavioral therapy, and again I'm going to get into explaining what it is a well-researched approach to treatment. And that treatment in general, but specifically the treatment of chronic pain. Except I would say in the last 10 to 20 years, acceptance and commitment therapy has really become a well-established complementary and sometimes apparently, competing paradigm when it comes to the treatment of ongoing or persistent pain. And I read an article a few weeks ago that it was shouting very loud the fact that we don't have enough Canadian samples to draw from, and so the people that are being researched are in Scandinavian countries or in Europe. So let's start with a quote from Chris Ecclestone, who's a well-established researcher of chronic pain in the UK. And he says, persistent attempts to react and adapt to pain, because that's what this is all about, right? Like we are looking at, okay, how am I responding to my pain? And its widespread destructive consequences often result in a range of emotional problems, chronic persistent pain, fear, depressive symptoms, and inevitably have negative effects on other aspects of cognition. So our experience has an impact on how we think and how we see the world. So assumptions within cognitive behavioral therapy that humans actively process information. We're learners, we're sense makers, and that our cognitions or our thoughts actively interact with our physiology, our emotions, and our behaviors. And I want to stop us there because, do we think that that's true or not? And what I'd like to have happen is, if you can, I want you just to remember the last television show that you watched that had an impact on you. I don't know if any of you are watching Breaking Bad, but holy smokes, does it ever have an impact on me? But imagine one that was really emotional. And if you feel comfortable, close your eyes and just let your mind go back to the memory of watching that show. Probably a good idea to choose a comedy, and just do it long enough. Try to focus on it enough that you begin to feel how you felt when you watched it. And again, we won't go too far into this, but this is a great way, if you haven't gone here before, to begin to see what we choose to think, what we pay attention to does have an impact on what's going on inside of our body, our emotions, and subsequently our behaviors. So I'll keep going. CBT assumptions, our behavior interacts with our environment, and you think about relationships and maybe even how we try to get support for coping with pain, or how we talk about our pain, how that impacts our relationships. So affect, feelings, our mood, and our behavior largely based on how we make sense of the world. I could go further, but I think that's just a good first blush on CBT assumptions. So to look at a standard CBT approach, it pays attention to how our thinking and our beliefs interrelate with our mood and emotions, other sensations in our body, and our behaviors or activity. This is another example that we use to begin to train or educate folks on the cognitive behavioral approach to coping with pain. And the question that I often ask clients is, if you think about your stress level, when you get stressed as you're going to physician visits, when your insurance provider is asking you to do things, when you're aware that you can't go do what you used to do, how does that impact your experience of pain? Or vice versa, how does your pain impact how much stress you feel? And so we begin to look at how our thoughts, behaviors, and mood interact, and sometimes then the patterns, if left unchecked, where it can take us. So what I'm going to do is this. I want to spend a minute on this slide, and then I'm going to go back to the previous one to get you to do an exercise. So to get to the complexity of, or the layers of thinking that are going on in a person at any one time, one of the theories is that we have 3 layers of thoughts. And I'll start at the deepest level. That would be our core beliefs, the level of values that we've chosen for ourselves, our morals, the level of identity, how we see ourselves in the world. Those are what fairly strongly held beliefs for most of us, and they're not easy to change. And at the next level, or maybe the level up, would be our intermediate beliefs. And that would have to do with maybe rules we have for how life works, our guiding theories about how to navigate the world, and expectations that we have. So I'll give you an example. If our working theories for how driving works in North America is that we all drive on the right side of the road. If you took that working theory to the UK, it wouldn't work as well, right? So we have, but some of the customs and beliefs we have about driving would still perhaps work. And that it's most important to spend time here on the level of automatic thoughts. And those are the thoughts that come almost instantly as we encounter pain sensations, as we encounter relationships, we encounter things in the external world, or memories. So these are our first thoughts, and they're often unnoticed. We don't often realize that we're having them, and they impact our feelings and our behaviors. And the good news about automatic thoughts is that they are the most amenable to change. So then if we go back to this diagram and think about, maybe here's an exercise for us to do. Imagine the last time that you had a spike in pain. I realize that there's about a 50-50 split as far as folks who are sufferers and folks who are more the clinical types. But I'd like to just go into this idea of, can you identify the thoughts that were there the last time you had a spike in pain? And often clients will tell me it's a cuss word, and this is going into the public record, so I'm not about to say the cuss word, but go from your initial response, maybe what the thoughts are, to how that impacted you on an emotional level. So if you imagine it's the morning time and you wake up and you feel that sharp stabbing sensation, the initial thought might be, oh no, right, or not again. And the impact on the emotions could be sadness, could be fear, could be anger. And so then how might that impact behavior? And it could impact it in a myriad of ways. You might stay in bed longer, right? Or you might get out of bed and just try to do whatever you can. Imagine that you get out of bed and the pain feels a little worse. Where do the thoughts go next? And I can't tell you where they go, but it's important to know your own patterns. Folks have told me that the next thought is, how can I do this day in and day out? And that thought, especially if you're not aware of it, can impact the mood even more, and depressive symptoms can creep in, or frustration or anger. And pretty soon that's going to guide what we do or what we don't do. And for many folks that I've worked with, there isn't an awareness of how this spiral can start and can take us to a place of feeling hopeless, or that there's nowhere to turn, or nowhere to no alternatives built into this. And so hopefully you've had a chance to examine or think about your own patterns now. But one of the ways where cognitive behavioral therapy can be helpful is to begin to identify, okay, what are those initial thoughts, perhaps the thoughts that flick this negative pattern in a particular direction, and then can I begin to examine those and begin to test them? Are they true? So we get to the level of, things will never get better, or we'll get to the automatic thought of, I'm hurting myself, for example. And developing a practice where you examine your thoughts, you test them for truth. Maybe you have hit medical closure in where you've been cleared to exercise, knowing the difference between sensations that are about hurting, right, or about a nervous system that's trying to protect you, even though it's maybe not helping you that much, versus doing damage. Knowing the difference between those sensations can make a big difference about what you think about the pain sensations and then what you do in response to them. So again, complexity of thoughts. The encouragement would be twofold. One, to know your own patterns. What starts you off on a maybe an unhelpful direction, and also what are some things that you need to remind yourself to get off that train before it gets going too far. So I started to allude to this idea of hurt versus damage. Asking yourself the question, have I done something dangerous? Is this a natural response to what I've done? Is this about my nervous system trying to protect me? And a great cognitive behavioral technique is just this idea of watching your thoughts and then beginning to invest in alternative explanations. So alternative explanations is this idea of noticing, okay, I'm having a reaction. What am I thinking? And is there another way to explain what my, what I've seen, what I'm perceiving? I'm trying to think if I can give you a good example of that. Alternative explanations, basically what it does is it breaks us out of believing one thing and allows us to consider alternative reasons as to why things have happened. So I'll be very just straightforward, hurt versus damage. So we have someone who is doing a physical program. They're trying to increase the amount that they're working on. They've got a low back, a disc problem, but they've been cleared to exercise, and going up to the machine and beginning to work on it, the pain flares up, significant spike in pain. At the beginning of their time in program with us, they would be distressed, and they would say, you guys are trying to hurt me, you're trying to make things worse. I know something's being made worse. But after they've gotten a bit of training on how to understand the fact that perceptions, what goes on in the body emotionally, that experience of distress, and also have gotten, of course, the medical clearance that in fact you are safe, commitment to then saying, I know that this is a hurt experience, but it's not a damage experience, and I know how to handle it, right? I can use diaphragmatic breathing. I can do as much as I can do. I won't do too much. Being able to make that shift in how they perceive, again, sort of the thinking or the thinking framework, decreases the amount of distress felt when the hurt kicks in. And that links back to this idea of, what's the automatic thought that sets it all off. Just thinking about where I want to take us here, because I'm aware of the time and I want to make sure that we give a good amount of time to acceptance and commitment therapy as well. Let's land on this slide for a minute, because I think that without having this kind of discussion, sometimes it's too much to expect folks to just immediately jump in and apply new techniques. And so here's what I've seen as a psychologist in pain management for the last 6 years. The transition from having an acute injury where you're getting physical treatment, sort of treatment from the medical system, expecting that in a certain amount of time this is going to resolve itself, to getting to the end of that where all the medical treatment that should have been done has been done, but pain persists. That transition from acute to chronic is very difficult, because you're moving from assumptions that we can cure you to, oh no, now we can't cure you, now you need to deal with this from, in a different way. And people often don't have a good experience going from acute to chronic or ongoing persistent pain. As people do that transition, it often what it does is it undermines your sense of who you knew yourself to be. Here you are, you've gone through the medical system, you're moving forward, and you've got persistent pain that's preventing you from doing what you used to do, all the different roles. It's impacting how you understand yourself. And so making that transition, and here's, I'll land this on that whole idea of cognitive behavioral therapy, understanding that going through that transition includes a significant series of losses. It's very important to then identify that, okay, as I've gone through loss, and as I'm now trying a new way of doing things, I need to make space for grief, because a natural human response to loss is grief. And without making space for that, and again, if we go back to where we were earlier, without making space for, this is normal for me to be upset about the transition that I've gone through, people can get stuck in moods, stuck in patterns of behavior that will prevent them from getting to a place where, wow, I can move forward even though I've got persistent pain. So I wanted to say that. I'm hoping it's coming out as clear as I want it to. But again, this idea of how your brain, how you make sense of your thoughts, how you make meaning of what's happening for you is an important part of cognitive behavioral therapy. And if you don't have a proper understanding of or a validation of, yes, in fact, it makes sense that you're grieving. Yes, it makes sense that you feel disoriented because who am I now that I can't be who I thought I was? That's the important starting point. With cognitive behavioral therapy, we fall into different mind traps that prevent us from being able to see our situation differently. And I just want to speak to one on this slide, and that's this idea of can't do. And I spent years talking about this idea with a friend of mine, Dr. Toya Oyalesi was his name. And we identified that if you haven't done grief, if you're sad, it impacts what you think you can do or can't do. And so a lot of times when we treat folks, they are really aware of all the losses that they've gone through, and they're aware of what they no longer can do. And being aware of that, impacts sadness, and sadness impacts being aware of that. And that's an important process to go through, grieving the loss of not being able to do some of the things you've been able to do. However, the shift out of that is first to name, okay, I'm stuck in that, right? It's important, that grief response. I need to look at, the hard side of things, but that's not the full picture. The other side would be then to slowly begin to build a can-do list, right? That's a way out of that can't-do mind trap. And a lot of times folks tell me that seems really silly. Like, why do I want to write a list that says that I can breathe, right? Or that I can talk to people, or that I can enjoy outdoors, or that I can participate in a webinar. And it does feel silly to get going, right? Because really what you're doing is looking at foundational truths that haven't been taken away from you. But slowly and surely, when people begin to put effort into that, it loosens your mind's view of your state of affairs. You don't pretend that you haven't had significant loss, but because you have. But then the other side of it is to begin to rebuild and move forward. Focusing on ability is a great way to come out of a very dark place. And it doesn't happen overnight. And I said at the very beginning, some of this stuff we spent a lot of time talking about. But understanding that, understanding that it's important not always to believe what our minds tell us. And there's reasons behind that. Okay, so that was a broad stroke view of cognitive behavioral therapy. We had a chance to practice diaphragmatic breathing. Hopefully you have a sense that your thoughts and feelings and behaviors are all interacting with each other. You had a chance to examine your own patterns of responding to pain sensations, right, or other conclusions. And there are techniques to be worked on with the cognitive behavioral framework. Acceptance and commitment therapy gets its name from its core message, this idea of, can you accept or come to terms with what is outside of your personal control, and then commit to action that's value-based, that allows you to live the life that you choose. I guess, the other piece around grief I wanted to say is that grief comes too from the fact that you were living a life where you had a particular dream for the life that you wanted, and then a life-changing injury, it shatters the dream of that life. And so again, making space for grief, I think, can then put us in a place where we can begin to come to terms with what is not in our control, and realize that we can move forward, thinking of that can-do list. So it's a little different than cognitive behavioral therapy. CBT is focused on changing your private experiences. And we talked about automatic thoughts, right? And identifying those and beginning to challenge those. And I didn't say much about positive self-coping statements, but if you're building a can-do list, reminding yourself, hey, I can do this. I can do, having that as your default, where you're aware of your automatic thoughts or choosing to insert thoughts in there versus just allowing your thoughts to happen and not being aware of them. It's really important. So the difference, though, with acceptance and commitment therapy is being able to develop the ability to see where your thoughts are taking you, see where your body sensations are taking you, and accept them for what they are, and then continue to choose what you want to do. So at the core is this idea of sometimes control is not the solution, it's the problem. I think what I want to say about that. I may come back to this slide because we could spend an hour and a half just on this slide dealing with think about the shift that I was identifying before between acute and chronic pain. At acute, we're doing everything we can to get the pain under control so that we can move on back to our regular life. People who have had pain for a long time have put a lot of effort into trying to control pain, manage pain. Some of it works, some of it doesn't work. And so maybe what I want you to take out of this talk today is a chance to examine, geez, what are the areas that I'm working so hard at control? Maybe I'm fighting my pain a little bit or a lot, and where is it not working? And where might be the areas where I can shift from resisting or fighting my pain experience just to choosing to allow it to happen, and what might come as a result of that. Take that as a teaser for what I'm about to say for acceptance and commitment therapy. So psychological acceptance, defined as the willingness to remain in contact with your thoughts and feelings without having to follow or change them. So acceptance of chronic pain is defined as living with pain without reaction, disapproval, or attempts to reduce or avoid it. And I don't know about that second statement, to be honest. I think without reaction is kind of a Zen state. But beginning to be aware of how do we react, and knowing your own patterns, and not necessarily unquestioningly reacting to pain. And the big thing about acceptance is it does not mean liking. And to be honest, I debated putting this slide in or not, because acceptance often gets immediately judged as, well, give up, right? This is the way it is, so just give up. And so I actually don't usually use the word acceptance, although I said acceptance and commitment therapy is for the talk, so I thought I would put that in. But I find this idea of willingness to make much more sense. So if you think about the direction that you're going in trying to change your experience of pain, I tell people all the time, hey, you need to hold out hope that things will be way better. But if you think about what's happening for you today, how are you feeling towards your pain? What kinds of words would you describe to explain how you feel about your pain or how you relate to your pain? A lot of clients tell me that they hate it, they resist it, they fight it. And then the next question would be, and what does that cost you? Right? How's that working? And oftentimes people will say, I'm exhausted. I'm so tired of fighting my pain. And it gives them a chance to kind of say, okay, well, maybe fighting or maybe resisting, because if we put up resistance to an unwanted experience, except the experience is there anyway, it typically leads to increased suffering. So that can be upsetting, and you think, well, okay, well, now what? If I stop fighting it, what are you saying? I have to love it? Well, maybe, right? And I know some of you might be yelling at me, but my hope is that as we consider these things, we consider what are we doing, is it working, and then is there another way to do it? And this is the paradox that I found to be quite powerful when people are looking at changing the way that they deal with pain, and that's this idea of willingness. So willingness is, might be described as, can you consent to experiencing without struggle difficult thoughts and feelings or sensations in the service of living out what you value? And examine when you struggle to try to change things, to decrease things, to change things, what's the impact? And so I absolutely poached this next exercise off of the portlandpsychotherapyclinic.com. But what I'd like you to do is close your eyes. Just imagine that someone puts a feather in your hand. And just hold it gently in your hand. It doesn't take very much effort at all, does it? Just imagine how it might feel. And then imagine that someone puts a very prickly, you know those cactuses that have just tons of spines? Puts a very prickly cactus in your hand. And now you could squeeze it, right? But imagine what would happen if you squeezed it or fought it or even try to get rid of it versus holding it very gently, allowing your hand to stay still. And the point of this metaphor is to again get an idea of what willingness might look like. I tease as well, and I don't know if my mother-in-law is listening, but I have I use this idea of mother-in-law because, lots of people wouldn't choose their mother-in-law, or can be difficult to get to know them and learn how to live life with them. And if you refuse or you resist your mother-in-law or whoever, think of someone that is in your life that you would not necessarily choose to have in your life, but they're in your life for whatever reason. If I resist, if I continue to hate, if I'm frustrated, if I don't want this to be, I suffer. Every time she's there or he's there, I suffer every time I'm around them. It's awkward, it's upsetting, it's frustrating. If I choose to say, okay, this is part of my life, it's not something that I would want, but I'm going to be willing to have it. Significant difference on a person's mood and emotional experience. Doesn't necessarily change, the fact that this person is in your life, right, or this condition or this unwanted experience. But it allows us then to be more flexible in how we deal with it. So willingness is not, it's not resisting your pain or ignoring your pain, doing what it says, not doing what it says. Willingness is something that is essentially the opposite of resistance. And so sometimes it is resisting your pain, I think. Sometimes it is ignoring your pain, right? Sometimes there are times when fighting pain is good. If your pain says to you, and again, this is anthropomorphization, but if your pain says to you, hey, you're not doing that today, I'm going to be loud and get in your way, sometimes we can say, you know what, I'm going to go there and be part of what I want to do anyway, right? So there are times to fight your pain, but there are other times to be willing to have that experience and not resist it. So at this point, I would love to be sitting here talking to you directly so you could push me to define myself if it's not making sense. But I'm hoping you're getting the idea that willingness is one of these paradoxes when it comes to dealing with persistent, intense sensations, persistent pain that has actually been quite helpful for some people. So based on time, I'm going to leave over this quote, but it's a great quote from an important book called Viktor Frankl's Man's Search for Meaning. And I want to jump to mindfulness. And buyer beware here is that I'm not a mindfulness expert. However, I've exposed myself to enough training and lessons and basic practice that I can give you the overview and then offer you a good start with some good resources. So mindfulness has a lot to do with practicing staying with the present moment. If you think about it, our minds are often racing ahead or impacted by what's come before. And so staying with the present moment means that we need to focus on our senses that put us in the here and now. Mindfulness also is about developing the ability to watch what's going on in our experience. Watch and not judge. So to pay attention to how is your body responding right now. To pay attention to what kind of thoughts are you having, even about this talk. What kind of feelings are you having? And practicing this allows us practical experience, to observe that all of our experiences are generally transient. When a person goes through a spike in pain, or we call it a pain flare-up, it doesn't last forever. Sometimes it feels like it will, but it often doesn't, not to that high intensity. And so developing this observation of what the place of observation can be actually give you a bit of distance from reacting to your experience. So I want to try to make it really practical. So let's go back to this idea of hate, right? If you hate your pain, or if you, strongly dislike your pain, you can begin to practice watching, okay, there goes my mind again. There goes my feelings again. They're having a strong judgment about my experience. And to practice taking curiosity about what your mind and your body do without having to live in reaction to that hate can begin to open up a whole new world of choosing, how it is that you want to respond, and accepting the fact that the body's going to resist pain experience until we develop the ability to watch and say, okay, maybe I do have more of a choice on how I react to this emotionally. And just the quote, go back and read it, because the quote really speaks to that in a profound way. So let's shift into practicing again. And I don't want to go to the deep end. I think what I'd like us to do is just go back to that idea of diaphragmatic breathing. So take a nice deep breath in. But I really want you to pay attention to the breath as it comes all the way in and all the way out. And I want you just to pay attention to how this talk is impacting you. And try not to judge it, just notice it. So nice slow breathing, be aware of your breath. Just notice what you're aware of, maybe in your stomach or in your head. Notice what emotions are sitting with you. You might be sitting with, gee, I wish this guy talked slower. I'm frustrated. Just be aware that, okay, that's part of my experience right now. Slow breathing. Just be aware of what it's like to sit where you're sitting and to move out of being in the cognitive channel and into being aware of your surroundings and what it's like for your body to be sitting where it is right now. And if you notice that you're sitting inside of evaluation or judgment, just be aware of that. Oh, my brain is telling me that I love this guy. Oh, my brain's telling me that I can't wait for this to be done. Either is okay. Just be aware of how your brain is responding. So in the sake of appropriate transitions, just take 3 more slow breaths. And remember what I said before, going in and out of this might be difficult, and that would be normal. I think it would frustrate me. But on the other hand, it's important for us to have experience of what we're learning so that maybe it'll stick or at least promote curiosity. Okay. I remember at the end of this talk, I've got some really practical resources that I found to be very useful in my clinical practice. So I think we've got about 3 minutes left. So I just want to tell you a story that helped me realize that I had put too much emphasis on psychological methods to deal with suffering and not enough to help people actually focus more on pain control. So I was working with a fellow who was just about ready not to go back to work. He had done a whole physical rehab program, but he couldn't sit down. He was sitting tall. He had too much pain when he sat down. And so I thought, okay, well, I'm going to, try to teach this guy suffering management type skills. And he did a good job. His mood was well managed. And then I thought, okay, it's been a long time since you did the pain dial intervention. And so the pain dial is essentially getting someone to get in a relaxed state, to see a dial in their mind and be, identify, okay, out of 10, or in this one, 12, where's your pain at? And then can you slowly turn it down and see if that actually impacts how your pain level directly. I had a few good experiences with this, but didn't use it on a regular basis. So we started to do that. And, the guy was a bit frustrated. I don't think this is working. And so for some strange reason, I remembered, oh gosh, you know what? What if I added a willingness dial here? And so we could simultaneously, or one at a time, turn up this guy's willingness to have pain. And just even beginning to talk about that, he was able to identify and move through some very difficult feelings he had towards his pain. And then with practice, he was able to turn up his willingness to have or to experience pain as it was right there and then. And it didn't take away his pain, but it decreased the stress that he felt around his pain. And it just changed his ability to kind of even think about what was happening. So then we moved back to the pain dial. Once he was in a much more willing state, and lo and behold, this guy actually had an experience where he was able to bring his pain down, I think 4 notches out of 10. And it was profound for him, and that began a pattern of him practicing this and paying attention or holding both this idea of willingness and pain control, one in each hand. And for him, it led to a fantastic outcome, which included return to work. And it just reminded me again about some of the learning and the things that we know about pain and pain neurophysiology and what's happening inside of your body actually does, with discipline practice over time, can have a direct response on the pain itself. So this is about, I think, 6-8 months ago, and I have really worked hard to try to hold control and suffering management together. So in summary, this stuff is hard, but it does work. It's important to start from the right starting point. Understand where you are in your process of transition. This is not something that you say, okay, well, the medical stuff's done. Here I'm going to go into pain management. It takes an emotional toll. It's important for us to study our own patterns of response to our pain, and also even the impact of how it's impacted how we see ourselves. It takes a lot of practice, and it's important to recruit support and accountability.
So I think we have a few questions, so I'll hand it over to Lisa if you want to do some of the questions.
Yeah, you can hear me now, yes?
Yes.
Yep.
A question from Marty. He said, I have fear that it is going to get worse in days to come. People around me just can't understand what I'm living with and how I am because of the pain. How do you work with this? People perceive me as being lazy and recluse. And there were a couple of other similar comments, people saying they thought I was looking for attention or just faking it. Sort of how do you deal with the reactions of others?
Well, where I've landed is really encouraging our folks that they need to take leadership in relationships. And I think treatment for families is really wise, because families often don't know what to do, and so they land on one side or the other, and then they can have their own experience of pain, right? They're frustrated, angry with the pain, but it's hard to articulate that, and that often comes off as frustrated and angry with the pain sufferer. So a few things. First of all, let me just develop the idea of taking leadership with our families and being able to name, look, this injury, I know you can't see it, but it's real and it's had an impact. Here's what I'm doing to try to improve my response to the pain. Let's talk about how we can begin to develop shared activities that we can do together that take into account both what I'm able to do and what I can't do. And being able to identify, here's what I need from you in order for me to be able to do that. So a great example of working with this couple, and the husband was doing less and less with her and with the family, and we used an ACT story actually to help them make better sense of how they dealt with pain together. And the story, I'll just do it in a nutshell, is you imagine that you are about ready to host a party and an unwanted guest shows up. And try as you might, we cannot get rid of this guest. He's impacting all aspects of the party. What do? Maybe you fight him, right? But that doesn't work, and the cops won't take him away. So then you begin to go, okay, how are we going to deal with this unwanted guest named Joe to make it so that we can host as much of the party as we want? And so for this couple began to talk about, Joe's interference in their life. And I'll never forget, he came in and he said, last night we had a really important family meeting, and I wasn't going to go. It was about a father who was passing away. And my wife said, oh, is Joe telling you that you can't go, or what's going on? And so they were able to have a dialogue around, okay, what would he need in order to come? And he sat in this really intimate, important meeting, and he brought a mat, and he brought a bolster pillow, and he still participated. But because he and his wife had talked about, hey, we need to do things different, right? So we can continue to live out what it means to be family with this, hopefully temporary, but who knows, interference. So taking leadership and talking about, having that intimate discussion about, okay, what do we need from each other? And realizing that it's okay for your family members to have their own reaction to your pain, and talk about, okay, how can we, divvy up the idea that it's not you, it's my reaction to your pain and how it's impacted our lives.
Okay, Laren asked, I'm having great difficulty understanding if you're in chronic pain with no known reason. How can hurt versus harm work when you don't know which is which? I wish I could say the pain from my exercise program is hurt versus harm, but who knows which is which in chronic pain? And we had a couple of other people wanting some more discussion about hurt versus harm.
Great. So it's important to track down this idea of pain neurophysiology if you haven't already. And I don't think I gave a great example of that. So that's something that I'll have to get to you. The other piece, though, too, is that if you understand, if your pain is myofascial, right, or if it's moving all over the place, or if it's not coming because of some, sort of specific diagnosis, then this self-talk around your brain, right, and your nervous system generating a pain response, which is a true pain response, but it doesn't really fit the injury or the non-injury. It's important to, once you sort of put your finger on that, to practice cognitions or practice thinking patterns around, this is not doing damage, right? I can manage this pain, right? This pain is unwanted, it's upsetting, and then go down that road that we talked about today. But if you have confidence that you're not doing yourself damage, and I'm not sure if I'm answering your question because it sounds like maybe you aren't, and if you aren't, definitely see a physician. But if all the tests have been done, it's been determined to the best of the ability that you're not doing damage, then to land on this idea of, this pain hurts. It could be hurting because, my brain is producing pain when it shouldn't be, right? It's hurting for whatever reason, overreactive nervous system. Then you can begin to get into that can list, right? And use different ways of managing pain so that you can have confidence in moving forward. And I absolutely realize that sounds trite, and there's a lot of research and there's a lot of relationship leading up to that point, but it's up to the person to engage with the information around pain neurophysiology, what's actually happening in the brain, the nervous system, spinal cord, all those pain reactions. Actually, a good place to start, if you YouTube, there's a chronic pain cartoon, and it's a good beginning framework that can help give a person confidence to say, okay, this isn't about upcoming surgery that I've been told to have restrictions, in my behavior before I get to the surgery, but this is actually a pain disorder, right, where my body's producing pain that, maybe it shouldn't be, or for the wrong reasons, it's true pain. But then once you've landed on that place of, okay, it's okay for me to go forward, self-talk around the fact that this is hurt and not doing damage can really be an important step in developing confidence.
Hannah wanted to know, one of your slides talked about systemic influences in perception of transition, and she just wondered if you can just talk a bit more on that, about that.
Absolutely. You know what, there's been a lot of family docs that have said, you know what, this is not a physical issue, it's a mental issue. Go and talk to your, go and talk to a psychologist, right? Or it's some docs have said it's all in your head, or been clumsy in the way that they've said it. You know, we just talked about sort of systemic influences around family, you know, and that idea of family can be sort of concluding that, okay, this is a laziness issue, right, or they don't want to get better. Trying to equip the medical system to name, you know, all the different dimensions, have a biopsychosocial model on pain is an antidote to that. But if they don't have that, that transition to dealing with a persistent pain problem can be very difficult. So it's systemic. I guess what I mean by that is sort of relational, societal, cultural views as you transition from acute, like you're in the medical system, you're waiting for your doc to do something. So essentially you're in many ways passive in the medical system, and then going beyond into you know, beyond the medical system, it becomes the sufferer to be the primary person to take responsibility for what's going on and get educated. And it's a really difficult transition. And if the grief, in my opinion, if the grief work isn't done or acknowledged, it really prevents a good transition from one to the other.
Laren had a question about sort of loss of identity from not working and struggling with that, and just if you had any suggestions on how to cope with that.
Yeah, well, and you know, again, we very much come to see ourselves as you know, we are what we do. And years ago I used to run an addiction counseling group, and you know, similar. I had an aha moment where I met with the group for the first time, and I just said, okay, I just want to know who you are. Who are you? And I got, well, I'm an addict, right? Or I'm an alcoholic. Okay, yeah, but who are you? You know, and they couldn't go there, but with some coaxing and some good questions, getting into that space of, well, I am a father, right? I'm a brother. I'm a citizen. I'm someone who believes this. I'm someone who believes that. I'm someone who values love. And moving, it takes some work, and it can be quite disorienting, especially if you haven't worked for a long time, to begin to kind of name who are you and how does that fit with the values that you want your life to be about. And you know, broadening that sense of who you are beyond I'm someone who used to, and it could be important, I'm someone who used to, but if you know, I often say to clients that if we're not careful, our identity can become circumscribed by pain or by victimhood. And it's not that you're not a victim if you've had a terrible accident, but that those identities can become quite rigid, and asking questions related to who else are you, and also re-examining, okay, what is my value system? It's a lot of good resources just on the net to begin to look at even what values are. Can loosen that. It's a good starting point anyway. Again, having someone to talk to about it makes a big difference as well.
I just want to thank everyone for attending today and for your great questions. We got some really good feedback as well. Matt, there was a lot of appreciation for your talk and a lot of finding that it was a wonderful explanation of CBT as well as acceptance therapy. So thank you very much for that.
Right on.
And thank you very much for being here, and we will hope to see you at our next one.
Okay, great. Hey, thanks, Tanya.
Thank you,
Bye-bye.
Matt.